Good afternoon. I'm Dr. Thomas. I work in internal medicine and pediatrics. And my grand rounds is on an update on the medical hazards of air travel. So some of the concerns regarding air travel are exacerbation of chronic medical conditions, the risk of thromboembolic disease, acquiring communicable diseases, as well as having in-flight emergencies. So some of the background, there are nearly 2.7 billion passengers that fly annually. The Air Carrier Access Act of 1986 basically ensured that patients with, or passengers with disabilities or chronic medical conditions are able to fly without discrimination. There are environmental and physiological changes on the aircraft that may exacerbate a chronic medical condition. And then the incidence of in-flight medical emergencies are 1 per 604 flights. So some patients may not realize how the environment on the aircraft may affect their disease. Some of our patients are pretty internet savvy and will go on the internet seeking advice. And oftentimes the internet will direct them to get clearance from their physician. So here are some general screening questions. You should ask your patient that comes to you about the length of their journey. Have they had any problems during prior air travel? The conditions of their destination, such as public health concerns or their access to medical care where they're going. Also, have they had any recent exacerbation of their chronic medical conditions? Some of the literature says you should also assess if they could walk 50 yards at a normal pace, or ask the patient if they could climb 1 flight of stairs without becoming symptomatic. So if we look at more specifically, let's look at chronic heart failure, for example. One study of 464 patients, they were given a survey. These patients had chronic heart failure. 54% of those had traveled by air since they were diagnosed with heart failure, and 65% reported that they really didn't have any health-related concerns during their travel. So for most patients in that sample, well-managed CHF, air travel was safe in those patients. There's a unique environment on the aircraft, which we'll talk about later, but primarily there's concern for hypoxia. And Hobkirk did a study of 21 patients with NYHA grades 2 and 4 heart failure, and their ejection fractions were less than 40%. They were lying supine, breathing 15% oxygen, and their arterial oxygen sat dropped to 86%, but they did not have any significant symptoms as well. And the ICE study, there were 72 volunteers, men around the age of 54, who had NYHA grade 2 heart failure, and they were simulated a 7-hour flight. The mean oxygen saturation at sea level was 94%, and then at 2,438 meters, which that's the number to remember for later, but that's what the cabin is pressurized to. This O2 sat fell to about 91%, but still they did not have any symptoms or dyspnea or changes in their heart rate. They compared these to males about 40 years old that did not have any medical conditions, and they went from about 98% down to around 95% on the aircraft during the simulation, excuse me. So the conclusion, which led to the Aerospace Medicine Guidelines, was basically that patients who have stable heart failure, including grades 3 and 4, were able to do a short-term up to 1-hour flight with the hypoxia at rest and didn't have any deleterious effects. The grade 2 were able to tolerate up to a 7-hour flight. But if you have a patient that has severe decompensated heart failure, they'll need to be assessed for their in-flight oxygen need. And always remember that unstable patients, they can't fly until they're stable. So if we look at acute coronary syndrome, the British Cardiovascular Society guidelines, they divide these patients into 3 different categories. There's your very low risk, your low risk, and your high risk patients. So your very low risk, they're age 65 years, they're under 65, they have had their first event during that time, they've had a successful reperfusion, but the EF is greater than 45% and no complications. Those are your very low risk patients. Then the low-risk patients, according to the BTS, they have an ejection fraction of greater than 40%. They have no symptoms of heart failure, no evidence of an inducible ischemia or arrhythmia. And then you have your high-risk patients, which have their EF is less than 40%, and they do have signs and symptoms of heart failure. But their guidelines say that the very low-risk patients, they're able to fly as early as 3 days. The medium-risk patients may fly from 10 days onwards. And the high-risk patients, you have to defer flying until they're more stable. Now, the Aerospace Medical Association guidelines, which they were established in 2003, the BTS was from 2010. But their guidelines say that patients with an uncomplicated myocardial infarct should not fly for at least 2 to 3 weeks, or patients with a complicated myocardial infarct should not fly for at least 6 weeks or until stable. So other contraindications to commercial air travel from a cardiac standpoint, unstable angina, according to the guidelines, uncontrolled severe or symptomatic hypertension, uncontrolled arrhythmias, as well as severe symptomatic valvular heart disease. What about pacemakers? I know a lot of times when I'm traveling, I'll see people say, I have a pacemaker, and they're pulled out of line. And so some of the things you can tell your patients are to make sure they have the identifying card with them that tells what type of pacemaker they have. And they're also suggested that a hand search is recommended because there's a theoretical risk that the wand has an alternating magnet in it, and this magnet may cause the defibrillator to cause an inadvertent shock. But if the TSA still insists that they have to search the patient, then they're supposed to tell the TSA or request that they not hold the magnet over the ICD or pacer for more than just a few seconds, and that they provide at least 30 seconds between each pass. So I thought that was pretty interesting. If we're looking at a different system, Neurologic, so the guidelines recommend that patients who've had a stroke, that they should not fly within 2 weeks. They consider that to be a contraindication to air travel. Many neurologists make clear the patients, but just I guess as a general internist, if your patient is asking that question, I would say 2 weeks. They should wait at least 2 weeks. Epilepsy is not really a contraindication to air travel. But if a patient has frequent and severe seizures, they really shouldn't fly until their seizures are better controlled, which makes sense. And many times migraines are often triggered by airplanes and trains as well. And so some of the recommendations for those patients are to advise them to take their prophylactic medicine before they leave, and to also carry on their abortive medicines. Moving on to pulmonary, this is where a lot of the physiology of the aircraft really comes into play. Some of the contraindications are severe unstable angina. So patients just discharged with a significant significant asthma exacerbation shouldn't fly. Severe unstable COPD, that also is a contraindication. Significant hemoptysis, and also a patient whose baseline oxygen requirement exceeds 4 liters is considered to be a contraindication to air travel. So a little bit more about the environment on the aircraft as it relates to pulmonary. The cabin, the humidity is decreased on aircrafts, so it's decreased anywhere from 10 to 20%. With decreased humidity, you can have a drying of the skin, the cornea, but also the airway passages as well. And this may trigger respiratory complaints, especially in those patients that have COPD and asthma. Then we think about patients that have cystic fibrosis on a long flight, they can become dehydrated, and so there's concern that the mucus may become thickened in those patients. Again, air pressure. Also, the unique environment of the aircraft, gas tends to expand on the aircraft, so there's concern as far as gas expanding in the pleural cavity, possible pneumothorax, especially in those patients that have COPD or with Ebola or cystic fibrosis or any recent thoracic surgery. Also, the middle ear. I think sometimes when I fly, I have this kind of clogging of the ears, but the eustachian tube, think about pain, tinnitus, vertigo, hearing loss, rupture of tympanic membranes. And then the GI tract, the expansion of gas there leading to dehiscence of surgical wounds, bowel perforation with recent abdominal surgery, or bowel obstruction. and medical devices, such as urinary catheters or feeding tubes, areas that would have air in them. So pneumothorax is an area of controversy. Well, the guidelines sort of vary, but the Aerospace Medical Association guidelines was started in 1929 and pretty much is sort of the U.S. Guidelines. But they say that a pneumothorax is considered an absolute contraindication to air travel. Makes sense. And they also recommend that you delay air travel for 2 to 3 weeks after resolution of a pneumothorax or uncomplicated thoracic surgery. That's from 2003. The British Thoracic Society, they updated their guidelines in 2011, and they suggest that you delay air travel for 7 days after resolution of a pneumothorax, delay air travel for 2 weeks after resolution of a trauma-related pneumothorax, or delay air travel for 7 days after full lung expansion in patients who have undergone thoracic surgery. And then patients with a closed pneumothorax should not travel on commercial flights. So a little bit more about COPD and air travel. Some of the concerns are that the patients are potentially at risk for altitude-induced hypoxemia, expansion of the gas, as we mentioned before. And some of the literature stated that up to 33% of patients with COPD will develop PO2 of less than 50 at the 8,000 feet, which is what the cabin is pressurized to. In those patients, they're recommended any patient with a PaO2 between 50 and 60 or lower should have in-flight oxygen. So I like this diagram because it kind of shows you sea level, then Denver, and then the commercial aircraft cabin, which this is where most of the cabins are pressurized to. So you can see that you're a little bit beyond the mile-high city, as they say. On this graph right here, so, one second, sorry. So this A shows, this is sort of a person that doesn't have any pulmonary problems at sea level, and you can see that their PaO2 is around 95, and then as the cabin is pressurized, the PaO2 goes to about 65, which correlates to an your oxygen saturation of about 90. Over here, this is a person, so for example, with COPD, who may have a lower pre-existing PaO2 of about 70, and then when the cabin gets pressurized to the 2,438 meters, the 8,000 feet, their PaO2 drops to about 53, which correlates to 84% SaO2, and so these patients would need to be on oxygen. The gold standard for oxygen for air travel is the Haas testing. Many hospitals don't do it. It's more practical to do the baseline pulse ox and a 6-minute walk test. And so the pre-flight saturation of 95% or greater, they're not going to need any in-flight oxygen. If the pre-flight saturations are less than 92%, then they're recommended in-flight oxygen. But if they're between 92 to 95, you'll do the Haas testing. And actually, MixApp has a question about the Haas testing on it. But between 92 to 95, you'll do the Haas testing, or the 6-minute walk is recommended. And in general, if you aren't able to get any of that testing done, the patients will ideally start at a rate of 2 liters per minute, or if they're already on oxygen, you would increase the rate by 1 to 2 liters over their baseline. So oxygen is a big issue with the airlines as well. They have prohibited passengers from bringing on their own oxygen tanks on board commercial aircraft, and so the Department of Transportation, they'll provide oxygen for our patients, but they need at least a 48-hour notice, as well as a statement from the physician. So, as I mentioned earlier, another concern was respiratory infection. It's patients with influenza or TB, the air travel is contraindicated until they've shown some subjective improvement. But one of the most well studied is tuberculosis. And the guidelines recommend that those patients shouldn't fly until you have 2 consecutive negative sputum cultures after at least 6 weeks of incubation and the patient is clinically stable. And this led to, in 2007, the United States implemented a do not board list for patients with communicable diseases. And there were 33 patients on this list, and all of those patients had infectious pulmonary TB. And some of the requirements on the list are patients have, they have a communicable disease, they're considered to be a threat to other passengers, and they've avoided public health recommendations. So. Other contraindications to air travel are the nasal and sinus, such as severe sinusitis, large obstructing polyps, any recent nasal or facial surgery within 1 to 2 weeks, and again, severe recurrent nosebleeds. When we think about surgery, surgery it really sort of depends on the surgery, but in general, surgery is discouraged within 2 weeks. You should wait 2 weeks to travel after surgeries. Some of the guidelines say that simple laparoscopy, or colonoscopy, you can travel after waiting 2 days. Excuse me. Scuba diving, I thought this was interesting. Now they have dive computers. Does anyone scuba dive in here? Okay, so maybe, are you familiar with the dive computers? But the dive computers, they actually calculate when it's safe for you to fly. So they look at the number, the depth, and the duration of your dives, and you plug in your anticipated flight, and then they tell you when it's safe for you to fly. But if you don't have that technology, then it says that you should not fly unless you wait 12 hours after a single uncomplicated dives. But if you do multiple dives requiring at least one or more than one decompression stop, you should wait ideally 2 days. Some of the literature said you could get away with 1 day, but ideally it should be 2 days. Pregnancy is generally safe for air travel. ACOG didn't have an official statement on it, but they did say, but many of the airlines recommend that beyond 36 to 37 weeks gestation that you get approval from your doctor. And first trimester abdominal pain or bleeding, the patient should be evaluated for ectopic pregnancy prior to flying. And of course, they may be at risk for DVTs in general. So speaking of DVTs, some of the risk factors are age, it's increasing after 40, height, patients who are actually under 5'5" or over 6'1", which I found interesting, or body mass index greater than 30. And the flight duration, single long-haul flights of more than 8 to 10 hours, as well as multiple long-haul flights of at least 4 hours, and then more frequent flights of any duration within a short time frame. And I was on a plane recently, and I kind of asked the stewardess about this, and she says that now they're encouraging the passengers to walk around, wear their compression. She showed me some literature that they have on it. But the stewardess, they're also walking around all the time, because I said, well, man, maybe you guys are at increased risk, but they're constantly moving, and so I don't know of any studies that have looked at that. So some of the recommendations to reduce the risk of venous thromboembolism are encouraging hydration, avoid alcohol, caffeine, and sedatives, to not smoke. You can't smoke on the aircraft anymore. Constrictive clothing, avoid crossing the legs, and then changing positions and getting up every 2 hours, especially on some of our residents take really long flights, and they're encouraged to get up and walk like every 2 hours. And the aircraft, the literature was on some calf muscle exercises and some ankle exercises that you could do too, and also graded compression stockings. So a little bit about pre-flight counseling, just kind of general for the internist. It would be good to tell our patients to make sure they have a detailed medication list with them. And timing of medications is important. Some strategies are, if it's a short flight, then keep a watch that has the home time on it. A little bit longer flights, or you're going to be in a different place for a longer period of time, then adjust the schedule by 1 to 2 hours daily. Or an immediate change to the local time, but you can't do that with insulin. And also with insulin, when you're telling your patients to prepare, flying east, they have less daytime, so they may not need as much insulin, whereas flying west, they have more day, and so the day is longer rather, so they may need more insulin. So something for the patients on insulin to think about, and they should carry their insulin on with them. Also, they should have a list of their diagnoses, in-flight medications. Cardiac patients should have a copy of their recent EKGs. And then patients with severe allergies should have a medical alert bracelet as well. So sometimes on the aircraft, you'll hear the call, is there a doctor on board? I was flying with the OBGYN friend once, and she just kind of looked at me like, what am I going to do up here, at 30,000 feet? So, but the lady was coming from Vegas, and she didn't take her insulin, basically, is what happened, but she did okay. But the New England Journal of Medicine did a review of in-flight medical emergency calls, and they looked at 5 domestic and international airlines from January of 2008 to October of 2010. And there were approximately 11,000 in-flight medical emergencies that resulted in calls to the center, and we'll talk about that. And as I mentioned before, the incidence was 1 per 604 flights. The most common occurrence was actually was syncope in the majority of the in-flight medical emergencies, and then respiratory symptoms, nausea, vomiting. But there was a doctor that assisted about 48% of the time, and the aircraft had to divert once. One of our residents just graduated. She was actually, a man died on the plane, and she was coming from Dubai, and they had to turn around. So it took about 6 hours for them to go back to Dubai. But some of the follow-up data that they found were 25.8% were transported to a hospital by EMS. Of those, 8% were admitted, and only 0.3% died. But the most common triggers for admission were possible stroke, which kind of correlates with the syncope, pre-syncope that we were thinking about, respiratory symptoms, and cardiac symptoms. And that was New England Journal of Medicine, May 2013. So just take a moment to briefly look over this, especially for the residents. But if you're in a situation where it's an in-flight medical emergency, remember that the pilot is that's the person that has the ultimate control over everything that's going on. Usually you'll be connected to a ground crew. But some of the things are to identify yourself, have your credentials with you when you fly, and the stewardess and the flight attendants, they'll be able to assist you. Most planes do have an AED on board, and most of the times you'll be talking with the ground crew. I think one resident is not here, but I think he has some experience with this as well. And then if a patient has pre-syncope or syncope, you really want to get them out of the aisle and try to assess them and see what's going on. And then for the patients with chest pain, remember that you have an AED, and you're also able to kind of get your directions from the ground crew. So really it's about communication. The Good Samaritan Law really protects against any sort of malpractice if you're volunteering to help out. They did several studies, and the most common reason for people not helping was that they were worried about being sued later, except for there was a residency program in New York. They studied 52 residents and attendings, and none of them cited that as being a problem. But the Good Samaritan Law does protect you. You just have to make sure you're medically qualified to perform the service, you act voluntarily, act in good faith, and do not engage in any gross negligence or willful misconduct. And there's no monetary compensation. I found it interesting. It says seat upgrades and travel voucher are not considered as compensation, but that's what was in the law. Okay, so a little bit more about the risk. There's the traveler's thrombosis. The incidence of VTs after travel is about 3.2 per 1,000 person years. It's 3.2 higher than the healthy population. So there is a risk, and they've acknowledged that. As far as acute pulmonary embolism, 1.65 per million patients in flights that are longer than 8 hours, and then 4.8 per million in flights that are longer than 12 hours. So these are several studies that looked at the time interval for a venous thromboembolism screening after air travel. And you'll see that from as early as 1 day, all the way as far out by Hughes as 90 days, that a venous thromboembolism was possible. As we mentioned in the beginning, some of the concern about communicable diseases, such as TB, SARS, influenza. So the reported infections as of, this was 2011, was reports of two reports for TB, 4 for SARS, and 3 for influenza. So as far as tuberculosis, the flight attendant was the index case, and there were 2 documented tuberculosis skin test conversions that occurred during the 5 months in 1992. They looked at 212 fellow crew members and then 59 frequent flyer passengers. There was also a passenger with pulmonary tuberculosis that was traveling from Baltimore to Chicago and then on to Hawaii. And 4 of the 15 fellow passengers seated within 2 rows of the index passengers had a positive TB test. So this is some of the, this is a graphic of the big SARS outbreak, and I'll talk about it a little more, but just so you can want to take a second to look at it. The number of cases in the different countries. So I think there were 27 in the US, and then in Canada there were 251. You'll see that Hong Kong had 1,756 and then 299 deaths. So SARS was considered a global threat in March of 2003. It first appeared in southern China in November of 2002. And then, as I showed you on the graphic, it spread to more than 24 countries in North America, South America, Europe, Asia before it was contained. This was the Moy Gardens outbreak in Hong Kong. There were a total of 40 flights that they investigated, and 5 of those flights were associated with probable onboard transmission of SARS and about 37 passengers. And most of those passengers were seated within 5 rows of the index case. And the super spread flight was the 3-hour flight that was carrying 120 passengers traveling from Hong Kong to Beijing. On this one, there were 22 of 37 people who contracted SARS after their travel. And laboratory confirmed SARS coronavirus occurred in 16 people. And there were 2 that had a probable diagnosis and 4 were reported to have SARS. Some of the, there was influenza in Texas in 1979. Actually, the aircraft wasn't in the air. They were stuck out on the runway for many hours, and so there was an association with influenza with that flight. Also, a naval air station in 1989, military personnel that were returning from temporary duty, and then mine workers on another aircraft in 1999. So just in general, as far as infectious disease, the SARS epidemic, it really did indicate that air travel has an effect on infectious disease spread. Most commercial aircraft recirculate up to 50% of the cabin air. So if you're ever on an aircraft, I mean, you have your little vent thing up here, but if you feel it down at the bottom, you'll feel the air coming up from the bottom and sort of circling around you. And the air, it passes through a series of filters, maybe 20 to 30 times per hour. So the risk of infection is really greatest in flights that are longer than 8 hours and in passengers that are seated within 2 rows of the index patient. But if you think about the number of reports that I showed you and the number of flights yearly, it's really kind of small. So the perceived risk may be greater than the actual risk. So some of the future directions, creation of a database for in-flight events. Right now there's no standard database that documents all of the in-flight emergencies, and the airlines are not required to report them. And you may remember Captain Sullinger landing in the Hudson. Well, sort of after that, they started to really standardize the emergency kits that are on the planes, because that wasn't done before. And then a reassessment of the current screening guidelines. You can tell that the guidelines sort of vary, and some of it is really theoretical, but patients are often symptomatic and have been diagnosed after the flight. And then to minimize the risk of influenza pandemic spread that's associated with commercial air. You see there's an association, but really taking steps to minimize those risks. I think that's it. Went a little faster than I thought. Any questions? Any questions? Okay. Well, maybe you'll think about some of these things next time you fly. Thank you.